I'm a PGY4 in the OBGYN department here at South Brooklyn Health. And our study looked at the relationship between hemorrhage risk assessment tool score and peripartum quantified blood loss. So the Association of Women's Health, Obstetric and Neonatal Nurses created a hemorrhage risk assessment tool that helps clinicians to identify patients with risk factors for hemorrhage during hospital admission. This risk assessment tool is used and cited by the American College of Obstetrics and Gynecology. Safe Motherhood Initiative meets the requirements for Joint Commission standards for perinatal safety and has since been implemented all over the nation. In this tool, hemorrhage risk is stratified into low, medium, and high hemorrhage risk, evaluating for 10 components, which include body mass index greater than 35, admission hematocrit level less than 30, admission platelet level less than 100,000, estimated fetal weight greater than 4,000 grams, frank vaginal bleeding on admission, abnormal placentation, history of previous cesarean delivery, grand multiparity, which is defined as 4 or more vaginal deliveries, and current multiple gestation. Each positive response assigns the patient 1 point. A score of 1 is defined as medium risk, while a score of 2 or more is defined as high hemorrhage risk, and obviously no risk factors is a low risk for hemorrhage. So previous validation studies of this hemorrhage risk assessment tool utilize only estimated blood loss, as opposed to quantified blood loss, which is what is novel about our study. Quantified blood loss is well documented in the literature as a more accurate assessment of blood loss rather than visual estimation of blood loss by the surgeon. Our primary outcome was looking at quantified blood loss as a continuous variable to evaluate if increased blood loss was associated with higher hemorrhage risk. Secondary outcome looked at the ability of hemorrhage risk assessment tool to predict peripartum hemorrhage as a categorical variable. So basically it was yes or no, did the patient have a blood loss greater than 1,000 milliliters, which is defined as hemorrhage by ACOG. So we conducted a retrospective chart review of all term deliveries over a period of 5 years, which included over 3,600 participants. For our results, we found that the relationship between medium hemorrhage risk and quantified blood loss only approached significance with a p-value of 0.050, which we all know. Statistical significance is defined as a p-value of less than 0.050, but high hemorrhage risk was found to be predictive of higher quantified blood loss with a p-value of 0.02. On the other hand, when looking at hemorrhage risk as a categorical variable, when looking at hemorrhage as a categorical variable, we found that both high and medium hemorrhage risk had increased odds ratio for postpartum hemorrhage or blood loss greater than 1,000 milliliters. The strengths of our study, we had a very diverse patient population. Only about 30% of patients identified as white non-Hispanic. Another strength of our study is it was the first to compare hemorrhage risk to quantified blood loss. Weaknesses of our study include user error in calculating quantitative blood loss in EPIC and possibly inaccurate reporting of risk factors as well. So ultimately, we recommend that clinicians continue to use quantified blood loss when evaluating a patient for postpartum hemorrhage, as it provides a more accurate assessment of a patient's blood loss. And we also recommend that the Association of Women's Health, Obstetric and Neonatal Nurses recalibrate their hemorrhage risk assessment tool to include quantified blood loss instead of estimated blood loss. That's it. I just want to thank Dr. Jacobs and Dr. Vogel for all of their time, for really helping me in every aspect of this project, and also to the OBGYN department for their support.
Thank you. Any questions? Dr. Gutierrez? Anyone? Yes, Dr. Gill?
So, great study. Thank you for doing it. Thank you for presenting it.
Thank you.
Why is it that, everything that you've said makes great sense, right? Quantifiable versus qualitative stuff. Why does, obviously not an OBGYN, but prior to this, why was that the standard of care in a non-quantifiable, accurate way? Is there a particular hemorrhage risk assessment limitation as to why that was and why this is clearly a better way to go? Or?
Sure, thank you. The question was why, sorry.
Can you repeat the question for people in the back?
Sure.
They didn't hear it.
Yeah, so the question from Dr. Gill was, why is it that in the past, this tool was only using, if I'm abbreviating this correctly, why is it that it was only using estimated blood loss in the past and not quantitative blood loss? At the time that the tool was formed, which I think was like 2017 or 2016, quantitative blood loss hadn't really taken off yet as like common practice. Also, obviously in obstetrics, you deal with a lot of emergencies, situations where you can't necessarily quantify the blood loss. You can't really weigh chucks, weigh laps. If the patient is like actively hemorrhaging, really, you're on a time crunch. So I think that people or clinicians rather would have a better time estimating blood loss, especially clinicians with lots of experience would rather just quickly eyeball the patient. And there is some literature out there that says that really when you quantify the blood loss, whether you're estimating it or weighing it out, what's more important does the patient have clinical signs of deterioration? That some people define hemorrhage as that versus an actual number of how much blood was actually lost.
Thank you.
You're welcome. Any other questions? Thank you, Dr.
Thank you.
Thank you.